Hello, and let's begin looking at some of the chapters that are assigned for your readings for week number 1 for Nursing 228. The first chapter I want to look at is chapter 27, Principles of Growth and Development. In this chapter there are a lot of theorists. They talk about Freud, Piaget, and Erikson. For testing purposes, I'm really going to focus exclusively on Erikson's stages of development. You may find, especially with your teaching project, that you'll have to get into the Piaget's theory, but I think Erikson's stages of development are probably the most applicable and user-friendly when we're talking about nursing care for children. We're starting, I just want to kind of go through the different stages, starting with an infant. And an infant would be defined as from birth to a year of age. If you really want to get technical, from birth to 28 days of life would be considered a neonate, and then from that 29th day through their first birthday would be considered infancy. This picture, or this slide, actually comes from chapter 28 in your textbook, but just a few things to point out about the physical development of an infant. You can see a social smile typically at 2 months of age. Their first tooth erupts around 6 months of age. That pincer grasp, or you can think about when they can start to pick up those Cheerios or the piece of lint that's on the floor that they're attracted to, as opposed to all the toys sitting around them. One thing about a child's birth weight that it's important to keep in mind: a child will typically triple their birth weight by 1 year of age. We consider at about 6 months of age that they should have doubled their birth weight and then tripled it by a year. And again, you can see the other things on the slide: heart rate, respiratory rate. We know those will change as well as the child gets older. One thing to mention as we're talking about the different stages of development, and especially some of those developmental milestones, thinking about when should a child be sitting by themselves, when should they be walking, we definitely have some times designated as to when that typically happens. A lot of children hit those milestones well before that designated time, or that time according to the textbook and the experts. Some children may be slightly behind. You know, when do we become concerned? Well, when we see a child who is really lagging behind. You know, again, to use the example of a child walking. Typically, we think about that milestone being reached at about 1 year of age. Would I be real concerned if a 13 or 14-month-old came in and wasn't walking yet? Probably not. I'd certainly want to assess, is the child at least pulling themselves up to a standing position? Are they doing what we sometimes refer to as cruising, where they're kind of walking along furniture, holding on? You know, what about a child who appears at 20 months of age and isn't walking? Then we're starting to get, that could be a concern and cause for more investigation. So again, just remember those are general, we have those general milestones and time frames in mind, but again, some children may hit those milestones before, some a little bit after. According to Erikson, infants are in that trust versus mistrust phase. In other words, they kind of need to learn to know that when they're hungry, somebody's going to feed them. When they're wet, somebody's going to change their diaper. Or when they just need a little TLC, that someone will comfort them. If we want to think about how could this play in then to some nursing responses, certainly we want to make sure that the child, while they're in the hospital, their needs are being met promptly. Certainly even encouraging parents to room in, or that's the term that we use for a parent staying at the child's bedside or sleeping in the room with the child. We would want to encourage that, not allowing the child to cry for prolonged periods of time. And we probably also want to make sure that we're holding the baby. You know, we're not just going into the room, doing our nursing care, and then leaving the room again, but just spending some time giving that comforting, that kind of that human touch. The picture on the slide here is a child at about 10 to 11 months of age, and you're demonstrating how they develop that pincer grasp. Of course, I'm not sure what they're offering the child. It looks like it could potentially be some kind of choking hazard, some kind of washer or something. We certainly wouldn't want to offer that to a child of that age, but again, the picture demonstrates that pincer grasp. Stranger anxiety, also when we're thinking about infants that we may encounter in the hospital, is as early as probably 4 months of age. Infants can start developing stranger anxiety. So don't take it personally when you walk into that child's room and they look at you and just burst into tears. It's nothing personal, but again, you're a stranger to them and they're unsure. And we can see this stranger anxiety continuing on even into the toddler and preschool years as well. This picture right here again just shows you an infant about 9 months of age. Again, to get a picture in your mind, especially if you haven't been around children, you can see that this child appears to be sitting well without support. You can see as far as play activity, something that the child is enjoying as well, looking at their reflection in the mirror. Moving on to toddlers. And with toddlers, we're talking about children between 1 and 3 years of age. And again, according to Erikson, they're in that autonomy versus shame and doubt. This is when that toddler is really wanting to do things on their own and be independent. As a general rule, toddlers tend to be very negative. I always say toddlers have one favorite word. And I bet you can guess what that is. It is the word no. They, again, tend to be characteristically negative. So how does this come into play when we're dealing with toddlers, especially in the hospital setting? We certainly don't want to walk into a toddler's room and say, do you want to take your medicine? Because obviously, what's the response we're going to get? It's going to be no. Instead, we can give them a choice to encourage that autonomy, but again, make sure that that choice exists. It could be, do you want water or juice after you take your medicine? So giving them choices is important, but again, make sure that those choices do exist. The other thing with toddlers is they tend to be kind of ritualistic. So if they are in the hospital, talking with the parents and finding out what is their typical routine and trying to incorporate as much of that routine into the hospital setting as is possible. And we'll talk a little bit more about working with children who are hospitalized as well at the different ages. Just a few things physically about the average toddler. Again, this comes from chapter 29 in your textbook. You can see they will start to speak in 2-word sentences. Oftentimes that sentence might be I do or I do it. Again, thinking of that autonomy. Heart rate, you can see it's slowing down a little bit from what it was in infancy. That pouchy abdomen, kind of characteristic as far as a physical appearance goes with a toddler. And that lordosis as well, which will disappear as the child gets a little bit older. We do see some of that baby fat starting to disappear. They do have that wide-based or toddling gait. I put this slide in here, transition objects. With toddlers, these transition objects can really work well when they are hospitalized or if they're undergoing some type of surgery, be it inpatient or outpatient. We want to encourage parents, if there is a favorite stuffed animal or blanket, to bring that to the hospital. That even goes for, in the infancy as well, but certainly in the toddlers, they may have become attached to a certain doll or stuffed animal. And a lot of times, we can use that object to encourage the child to express their feelings that maybe verbally they're not able to do so as would an older child. It's not unusual for you to go into the hospital setting and see the child, say they have a broken arm. We may see kind of a pseudo cast placed on the bear or the doll's arm as well. Or if the child is in isolation, you may see that their bear or doll is wearing an isolation mask. The child may, when you ask them, how are you feeling, may not respond, but maybe if we say, how is Mr. Bear feeling, they may open up and share some of their feelings with you through that object. Now moving into preschoolers. Now, with preschoolers, we're talking about children between 3 and 5 years of age. And again, according to Erikson, it's initiative versus guilt. The preschool child is learning how to do things. They start taking pride in their ability to initiate activities on their own. I said the toddler's favorite word was no. When we get into the preschoolers, one of their favorite words tends to be why, because they're starting to develop that curiosity about the world, how things work. Thinking about capitalizing on that initiative when a child, a preschooler would be in the hospital, allowing them to handle some of the medical equipment. Giving them brief, simple explanations, again, to try to satisfy some of that curiosity, but again, we have to remember their limited cognitive ability at that age as well. So I always use the example, a common phrase that we use in the hospital all the time is, I need to draw your blood. Now, for most patients that you've probably encountered in the hospital, when you say you're going to draw some blood from them, they know that that's an invasive procedure involving a needle, probably a little bit of discomfort. To say to a 4-year-old, I need to draw your blood, drawing to them is crayons, markers, and paper or coloring books. So then all of a sudden when you appear with a needle, they're going to be totally taken aback and, thinking, hey, nobody, I thought we were going to have some fun and do some drawing and coloring. So again, we want to foster that sense of initiative, but be careful with the explanations that you're giving, that you're using words that they will understand. A few things about the preschooler, again, thinking of physical characteristics. This is where we see a child kind of starting to slim out a little bit, a little more childlike, a little less of that baby fat. They start to have a lot of increased coordination with their motor skills. Running, kicking, riding a bicycle. Think of a 3-year-old riding a tricycle. The 3-year-old and 3 wheels on the bicycle, if that's one way to remember that. Again, you can see as it's noted on the slide there too, their vocabulary is increasing significantly during this time frame as well. Just a few things about playtime. I didn't mention playtime with toddlers, and toddlers can participate in play, but typically when we see toddlers playing, we're observing something called parallel play, where the toddlers are sitting, there may be 3 or 4 of them in a playroom. They're all engaged in activities, and they may be sitting next to each other, but there's not a lot of interaction between those toddlers, unless probably somebody reaches over and grabs a toy that's not theirs, and we might see a little scuffle. But typically with the toddlers, we think about parallel play. When we talk about preschoolers and thinking about their play activities, we start to see much more imaginative and imitative play. This is where they want to play house and pretend that they're mommy or daddy, or play hospital, where they may pretend that they're the doctor or the nurse. So thinking about different types of toys, oftentimes that's some of the things or the type of play that you'll see preschoolers engaging in. Moving on to school age. Now, school age covers a wide range. It covers children from 6 through 12 years of age. And again, according to Erikson, this stage of development is industry versus inferiority. Basically, school-age children are striving to be able to be successful. They start developing a sense of worth from their involvement in activities as well as the success that they're having in school. School-age children tend to get very into collections, be that Pokemon cards. I don't know if that's still popular with the school-age children, or stickers oftentimes with the girls, or I don't have a school-ager anymore, so I'm not sure what the latest fad is. But again, you'll notice that oftentimes is a big interest for them. And again, if it's feasible, if they're going to be in the hospital for an extended period of time, maybe having the parents bring in a few things from that collection may help to ease some of their anxiety and lessen the stress that they're feeling in the hospital. Interest with school-age children. Believe it or not, schoolwork is of interest to them, at least probably for most of them. They may not miss the homework or the math test, but they miss that social interaction with their peers. Peers are starting to become very important as we get into school age. So the school age child who's hospitalized, yeah, they may be upset about being in the hospital and not feeling well, and maybe mom or dad can't stay with them, but they're likely to be equally as stressed because they had been invited to a birthday party at, I don't know, the zoo or something, and they were going to miss that, or their class was taking a field trip to COSI and they're going to miss that as well. The slide here shows computers. Obviously that's a big interest. Nowadays we could probably even bump that down almost into the preschool age group with that interest in computers, but certainly that type of thing is very a big part of those school age years. Last but not least are our adolescents. Now with adolescents, 12 to, I usually will say 18 years of age, although a lot of books, and I think maybe even your textbook may give 19 or 20 years even as that high range for adolescents. And that's fine, and don't worry about that. 12 to 18 for our purposes in here is certainly sufficient. I always say I dare somebody to go up to a 19 or 20-year-old and call them an adolescent and see if you could get away with it. But again, with adolescence, according to Erickson, it's identity versus role confusion. This is where the time when adolescents are really trying to develop their own self-identity, separate themselves from their parents. Sometimes it can be a time of some rebellion. Mom says black, they say white. Mom says day, they say night. So we get a little bit of that again, but it's a part of that adolescent trying to grow up, develop their own identity, their own belief system, values, etc. As the slide states here, it says the peer group does become a major influence in adolescent development, even more so than in the school age. The peer group is a big influence. The other thing to think about with adolescents is they're very focused on the here and now. They have that feeling of being invincible. So we can talk to them about, how their behavior now may influence their health when they're 25 or 30, but they're most focused on how is this going to affect me today. To support the adolescents developing self-identity, certainly when we're dealing with an adolescent, including them, if we're doing a health history, for example, not directing all of the questions just to the parent, but allowing the adolescent to supply some of those answers and be a part of that plan as well. Chapter 35 talks about nursing care of the ill child and family. The picture is an example here of using that transitional object like we had talked about in an earlier slide, I think with a preschooler, although this child looks to be a little bit probably more early school age, but you can see again a child getting ready for surgery, has the head covering on and the bear going with them, also with the head covering on. So again, just some of those little things that sometimes we can incorporate into our care to kind of lessen the stress and anxiety that a child may be feeling. Certainly when we're thinking about the meaning of illness, there are different factors that can affect how a child thinks about illness, their cognitive ability. Just to kind of give you an example of that, oftentimes toddlers and preschoolers may look at illness as a punishment, something that they did wrong. So we have to kind of keep that in mind when we're talking about some of those things. You know, they may think, you know, oh, I hit my brother when mom wasn't looking, and, you know, then I went out and fell and broke my arm, so it must be because I was bad, or it must be because I did something bad. Certainly past experiences and level of knowledge also can influence a child's understanding of their illness. Just again, a few things from this chapter that they talk about, and again, you can read in more detail in the Pilitary book, but just a few differences in responses of children and adults, differences between the two to illness. A big challenge when caring for children is the inability to communicate. You know, certainly infants and toddlers with limited to no vocabulary may have a problem expressing their needs, or if they are in any discomfort in trying to tell us what's wrong. So that can be a real challenge when we're caring for the pediatric population. And again, children aren't really monitoring their own care and those types of things, and certainly managing their fear. There may be lots of things happening to them, or they're hearing words being used that they don't understand. So that can be a real stressor, again, thinking about children who are ill. Other issues, again, nutritional needs, fluid and electrolyte balance, big differences between adults and children. And you can review those topics in the chapter. Thinking about preparing a child for hospitalization, when we're talking about pediatric nursing, we really have to think about the family as a unit. Because when a child is ill and hospitalized, we're caring for the child, but we also need to care for the family, because that child's illness and hospitalization is going to affect that family unit as well as affect each member in that family. For mom and dad, it may be stresses of taking time off of work, problems, you know, or perhaps a loss of income due to having to take time away from work. There may be stressors if the child is hospitalized, a distance from the family's home. So transportation issues may be a problem. Also thinking about if there are other children in the home. Parents want to be with the ill child at home, but yet still may have 2 or 3 other children at home that need to be cared for, so they're dividing their time between home and hospital. Looking at the different age groups, there's some good information on pages 1072 through 1074 in your textbook, thinking about looking at the different age groups and how we can prepare those children for hospitalization. Sometimes we don't have the luxury of having a lot of time in advance to prepare a child who's coming into the hospital. It may be an acute episode, and they, you know, go from home directly to the hospital with no advance warning. Other times, if it's a planned surgery, maybe a tonsillectomy, something like that, we may be able to prepare them. But you can review some of those different strategies for preparing the different age groups for hospitalization in your Pilitary book. Certainly thinking about promoting a positive hospital stay, and we could probably go on and come up with lots and lots of different ideas on how we can make the hospital stay a positive experience for both the child and the family. Hopefully during your clinical rotation you'll be able to see some of these things in action from the nursing staff at the different facilities. A few things on the slide here, certainly minimizing the length of stay at the hospital if at all possible. Sometimes that may be out of our control. Providing continuity of care becomes very important, especially thinking about those separation anxiety or stranger anxiety issues. As much as possible, if we can use primary nursing, that will help. What can we do to try to decrease some of that separation anxiety? Certainly encouraging the parents to room in. Most pediatric facilities will make accommodations for at least one parent to be able to stay at the hospital at all times with the child in their room. If a parent has to go back to work or isn't able to be up at the hospital all the time, we may encourage them again to bring some of those favorite objects from home, maybe even a picture of the family. Maybe there's another family member, grandma and grandpa, aunt or uncle, or family friend who could come up and stay with the child if the parent can't be there. And again, I'm sure you can think of a variety of other things that would be important. Sometimes distraction works well with children. We'll talk about the playroom in a little bit. And that can be a big distraction and kind of help to ease the stress. A few other things on this slide, again, similar to what I had said, promoting visitation. Certainly encouraging the parents to participate in care. Sometimes I think as the nurse we feel like we have to be doing everything. Feeding the child, bathing the child, changing their diaper, all those things. A lot of those things that the parent does every day with the child at home. So it's important to communicate with the parents and say, maybe they need a break from some of those things while they're in the hospital. Maybe they'd like nothing better than to be able to go down and get a cup of coffee while you bathe the child. But, maybe they really want to participate in the child's care. And so, again, you have to communicate with the parents. But again, encouraging them to participate as much as they would like. Sibling visitation, grandparent visitation, also very important. In the olden days, nobody under the age of 12 was sometimes even allowed to step foot in a hospital. Now we see children of all ages in and out of hospital rooms. And again, to think about supporting that family unit, having the siblings come and visit is important. Minimizing some negative effects of procedures. Your book talks about the use of a treatment room, where we kind of want to keep the child's bed that safe haven. Granted, they learn real quickly that treatment room isn't necessarily the most fun place to be, but again, at least they don't have to be fearful every time someone walks into their room that they're going to do something to them. Treatment room also is good because if we've got two children in a room, we're going to do a procedure on one child in their bed. Well, we can pull the curtain so the other child can't see what's going on, but they sure can hear what's going on. And if they're hearing that it's something that doesn't sound very pleasant, they're going to be trying to find the closest exit and make their way out of there, because what are they probably laying there thinking? Are they coming after me next? Certainly reducing or eliminating pain. We'll talk about pain assessment in a little bit, which has really been historically underreported and undermanaged in the pediatric population, although things have improved greatly in recent years. But anytime we can manage a child's pain, we're making a step in the right direction. As I said earlier, the maintaining the child's bed as a safe area or a safe haven is certainly important. Helping children maintain control. Again, even starting from the toddler, trying to develop that sense of autonomy, giving them some choices. Do you want to take your bath before you watch Barney or after you watch Barney? And the adequate play facilities. Again, the playroom, a great place to be. Those of you that are having clinical at some of the inpatient hospitals in the area, I would encourage you to visit the playroom area. It's just a great place to be. You know, the work of children is play. That's kind of a saying that's been around for a while. One thing to keep in mind with the playroom, that is the only thing that should be happening in that room, is play, nothing else. If you need to do a procedure, give a medication, whatever, to your child who is in the playroom, you need to go down, get them out of the playroom, take them back either to their room or the treatment room, whatever is most appropriate, and then allow them to return to the playroom. Just to kind of give you an example of why that's so important. Now, say the child that you're caring for has some PO meds. You gave them their PO med at 8 o'clock when you came on for your shift, and the child took it very well. You know, no problems. You gave it to them. They swallowed the pill, drank the liquid, whatever it was. Now it's 4 o'clock, and the dose of that same medication is due again, and the child's down in the playroom involved in a big game of Uno, and you really don't want to take the time to, you know, why interrupt the game and have them come all the way back down to their room just to take this med and then have to head all the way back to the playroom. You're thinking, oh, they did just fine, and I can just run in there and give this med to this child and it'll be no big deal. Well, it may be no big deal for that child. They might not blink or think twice about taking that medication while they're sitting there playing that game. But what about the other children that are in that playroom? Maybe their meds taste absolutely horrible. Half the time when they take it, it makes them sick, or they start gagging and they throw up. If they see that a nurse has come into that playroom and given one child a medication, now what kind of a scenario have we set up? Now they're thinking, great, now my nurse may be able to come in and maybe she or he is going to give me medication. So just keep that in mind with the playroom. The only thing that's happening in there is play. I really kind of talked about some of these issues back when we were going through the different stages of development in terms of promoting that growth and development. Just as a quick review, you know, with infants, what were some of the things that we had talked about with that, thinking of trust versus mistrust. Again, primary nursing, if at all possible. Don't allow the child to cry for long periods of time. Hold the baby often. Make sure we're meeting their needs for food and hygiene. With the toddler, again, offering them simple choices. You know, maybe even thinking of the toys that we want to offer them, things that will allow them to be a little more active or independent. With the preschooler, letting them handle some of the equipment, giving them some of those simple explanations. The school-age child, you know, encouraging that child to complete schoolwork while they're in the hospital would certainly be appropriate. Maybe giving them some short projects to complete because they are trying to develop that sense of industry. With the adolescents, certainly including them in their plan of care, getting, you know, speaking directly to them, respecting their privacy, offering some support and praise as they are making some decisions in the hospital. All of those things would be some examples of how you could be promoting growth and development while a child is, from one of those age groups, is hospitalized. These slides, again, you can kind of just review them, thinking about some play activities. You know, how could we do some of these things? Thinking of nursing care, if we're trying to do a physical assessment. Well, what can we do? Maybe some distraction with a puppet or Simon Says, those types of things. You can kind of read through. Again, that's also included in your textbook, so you can read it at your leisure as you're going through the chapters. Thinking about some health teaching. Again, certainly we need to make it age and developmental level appropriate, but using puppets, maybe making a game, depending on the child's age, would be appropriate. Looking at Chapter 4, Communication and Teaching with Children and Their Families, again, I kind of gave you the example earlier about a term that we use, I need to draw your blood. Well, we may sometimes refer to getting injections as, just a little stick in the arm. Well, again, remember, think about the words that you're using when you're talking to children and make sure that they're going to understand those words. If you say to a child, I need to get a stool sample, a young child, maybe even a school-age child, may be a little confused. The only stools that they know of are those things that they stand on so that they can reach something that's a little high up. They're certainly not thinking you're asking about their poop. So again, be cautious as you're talking with children to make sure that they're understanding the words that you're using. Again, certainly things that will interfere sometimes with communication. Age and developmental level plays a big part with that. Again, just based on their cognitive or intellectual level. Physical factors as well that may interfere with that, or again, technical terminology that you use. Showing disapproval, especially as we're getting into that school age where they really want to try to please, they may answer questions the way they think they're supposed to, rather perhaps than what would be a truthful response. This slide just goes over some teaching strategies. Again, certainly we have to think about gearing our teaching strategies towards the age and developmental level of our learners. Again, this chapter you're going to find helpful also to look through as you're getting ready to prepare for that teaching project, because it can give you some helpful ideas and you can think about how children of different ages will learn best. Different teaching tools, again, depending on the age of the child. Puppets and dolls may work very well with toddlers and preschoolers. Games, then, we maybe can start introducing as a child gets a little more into the school age. And maybe pamphlets, videotapes, again, as we get more into school age and adolescence. Moving on to Chapter 33, Child Health Assessment. Now hopefully the baby, if you care for an infant during PEDS, isn't going to be quite this upset with you as you would be measuring their head circumference, although I do like the picture because it shows you, when you're measuring a head circumference on an infant, you kind of want to go around that widest part of their head, usually putting that tape measure right above their eyebrows. But let's talk a little bit about pediatric assessment. One thing that I can't stress enough is thinking about vital signs in pediatrics and knowing the norms for the age of the child that you're caring for. You'll notice on your clinical worksheets where the vital signs section is, there's one line to put the norms in and then one line to put in the actual vital signs that you recorded. It's important to know what is a norm. If you're caring for a 2-year-old, you need to know what's a normal heart rate, respiratory rate, blood pressure for a 2-year-old, because if you don't know what the normal is, it really doesn't even make any sense for you to go in and take the vital signs, because if you take their vital signs, all you're going to have is a set of numbers that you really can't make any evaluation of. You can't say, oh, they seem a little tachypnic or tachycardic, or gosh, their blood pressure seems a little bit low. In Appendix G in your textbook is an outline with all the norms on the different ages. So again, you're going to be doing this each week in clinical, and I would encourage you to kind of start getting some of those numbers in your head in terms of, if it's an infant, what would a typical heart rate be versus an adolescent, which really then we're starting to kind of get towards those adult normals. But you need to know what the norms are for the age of the children that you're caring for. Height and weight measurements are also important. Weight especially, because all of our medications, including IV fluids that a child is getting, are all prescribed based on their weight. In clinical, you'll also be talking about fluid requirements, maintenance fluid requirements, and that formula is also based on their weight. Growth charts. You're going to be, with each child that you care for in clinical, you're going to be plotting their height and weight and their head circumference, if appropriate, on growth charts and looking where does that child fall in comparison to other typical children of their age. You have growth charts in the back of your Pilates textbook in Appendix E. And again, I would encourage you, I would say you could refer to those growth charts in Appendix E in your textbook. You'll notice that the growth charts are color coordinated, blue for the boys, pink for the girls. So make sure that you're using the appropriate one for the child that you're caring for. Just a few things about taking the child's weight. Infants are usually weighed completely nude. If you're not that brave, you can sometimes leave a dry diaper on them, but make sure you zero the scale with that dry diaper so we're negating the weight of that diaper. Obviously, the older child we're going to allow to stay clothed or with a gown or pajamas on when we're weighing them as well. Just to give you an example that you can plug in some of these numbers with the growth charts, I give you an example of a 15-month-old male. You can see his weight, 9 kilos, height is 81 centimeters, head circumference 47 centimeters. When you go to the growth charts, obviously we're going to go to the blue one, and you're going to look along the horizontal axis for the child's age, which would be 15 months, and then you're going to look along the vertical axis in the weight area for 9 kilos, and you're basically going to plot that or graph that and look at where do those two lines intersect. The 15-month line going up and the 9-kilogram line going across. Now, as you're looking at those growth charts, you'll notice that you have lines running from left to right across the page. If you look over to the right, you'll see that those lines are numbered, starting sometimes with 3 or 5, all the way up to 95. That's the percentile. So when you see where your point falls in relation to those percentile lines, you're looking at which percentile line is that point closest to. And then that's where the child's percentile is. Now again, with these, and you can do this on your own as well, Joey's weight is falling below that 5th percentile line, so that's how we would record it, less than the 5th percentile. Sometimes when children are falling in this less than the 5th percentile area, we would refer to that as failure to thrive, or sometimes that's abbreviated FTT. That's always a concern, for why is this child not growing and gaining weight as they should? Oftentimes in the children that you're going to be taking care of, that failure to thrive is related to medical conditions that the child has. Now, if you do his height, you'll notice that his height falls closest to that 75th percentile range. How would we interpret that? Well, if we gathered 100 children his age, he'd probably be taller than maybe 75% of them. He's going to be one of the taller children in his age group. His head circumference is recorded as 50%. How would we describe that? Well, that he's probably typical in terms of his head circumference for children his age. Just a couple things to keep in mind with the growth charts. Certainly we have to think about genetics. If we get a child whose height is in the 90 or 95th percentile, and both their parents walk in and are professional basketball players over the 6 feet tall, common sense is going to tell us that they're going to have offspring who are also probably taller than the average child. Then the opposite could be true as well. If their height is, falling well below the 50th percentile and both of their parents are 5'6" or under, again, genetics is going to play a part in that, and their offspring are probably going to be a little bit shorter. We look at trends as well. Probably not as concerned about a child whose height is consistently in the 25th percentile. Yes, their weight, I should say, in the 25th percentile. Yeah, their weight may be a little bit on the low side, but they are still maintaining a steady rate of growth. I might be more concerned about a child who maybe at their 12-month checkup was at the 50th percentile for weight, then at their 18-month checkup was at the 25th percentile for weight, and at 24 months was down to the 10th percentile. We'd want to really start investigating what's going on there that's causing this child's weight to really slow down. So again, you'll get practice in the clinical area with these growth charts, because for each child that you care for, again, you'll notice on, I believe it's page 3 of your clinical worksheets up towards the top, you'll be filling in all those measurements for the child that you're caring for and then plotting those on growth charts. Obviously, there are some variations to your physical assessment techniques that are important to consider if we're dealing with an infant versus a school-age child or an adolescent, and depending on the developmental level of the child. There's a nice table in your textbook on page 989 that kind of looks at the different age groups and gives you some more specific techniques. So I would encourage you to look over that. Just to give you an example, with an infant, if you walk into the infant's room and they're laying there nice and quietly, or mom and dad happen to be in there and are holding them and the baby's nice and quiet, first of all, do as much as you can if mom or dad are holding that baby, because what's going to happen if you go in, take that baby right out of mom and dad's arms, plop them in the crib, baby's never seen you before, baby's going to start crying. Probably by the end you'll be crying too, because you won't be able to collect any assessment data or get any of your vital signs taken. Again, if a child is nice and quiet, doing their heart rate, respiratory rate, save blood pressure, save temperature, because again, that's going to require you to have a little more hands on the child, a little more manipulation. Certainly with an adolescent, respecting their privacy, leaving genitalia for last, as they talk about in that chart as well. The preschooler, we've already talked about, maybe allowing them to do some hands-on things. So I think that table does a nice job of summarizing, some of the key things to think about when you're doing a physical assessment on a child. This example here, now that child probably is a toddler, but you can see the nurse or examiner letting the child kind of handle the equipment a little bit before they actually use it on the child. Chapter 38 deals with pain management, and as I said earlier, this has been something that's been really underreported in traditionally or historically in the pediatric population, although great strides have been made in the last 5 to 7 years as far as recognizing the importance of pain management in the infant and pediatric population. These are a few myths, and again, I have that bolded and underlined. These statements are not true, but myths regarding pain in children. Infants and children do not feel pain. I guess one of the things that always comes to mind with this, and maybe it popped into your head, would be the circumcision issue. It's very rare in this area, this probably part of the United States, for baby boys to receive any type of anesthesia prior to circumcision. If you've had your OB rotation, or as you're going into your OB rotation, I'll leave that for you to decide if you get to observe a circumcision. But we do know that infants do feel pain. You know, the old school thought was, oh, their neurological systems are immature, and that's not the case. The second myth, children always tell the truth about their pain. Well, why might a child not tell the truth about their pain? Well, maybe if they've been in the hospital and they really want to go home, but they're still having pain, but they're thinking, well, if I didn't have pain, that must mean I'm better and I will be able to go home. They may lie about being in pain. Maybe the last time they told the nurse they were in pain, he or she came in and gave them a terrible tasting medication, or they got an injection of some medicine, and they don't want that to happen again. Probably, I think historically we tend to see boys maybe being a little more stoic than girls, and being perhaps a little bit more discouraged in verbalizing a lot of pain, especially as they get into school age and adolescence. So again, they may be trying to please a parent or please the caregiver by giving them the answers that they want versus how they're actually feeling. Another myth, children cannot tell where they hurt. Well, that's not necessarily true. Certainly an infant or a young toddler doesn't have the verbal ability to tell us where they hurt. But we can certainly give children as young as 3-4 years of age some different tools that they can use to help describe their pain. The last myth, narcotics are dangerous drugs for children. Narcotics are no more dangerous for children than they are for adults, as long as they're given in the proper dosages. It's also important to think about, the side effects of morphine, Demerol perhaps, in an adult. Those side effects are still the same. Our nursing responsibilities are still the same when administering those medications to children. But again, keep in mind that just because it's a child doesn't mean they can't have a narcotic. But we want to make sure it's the correct dosage. This is also from your textbook from that chapter, and again, you can kind of read through there. Probably some of the similar things that I've talked about, looking at fact versus fiction with some pain, thoughts about pain in children. When we're thinking about assessing a child's pain, thinking about what are some questions for the parents and or the child. I'm using the word pain, but for a young child, we may have to use the term, ouchie, boo-boo, hurt, rather than the term pain. Questions to ask the parents. How do you know if your child is in pain? How does your child typically respond to pain? What has helped with their pain management in the past? A behavioral assessment. Certainly we can be looking at facial expressions, especially with an infant. What about sleep patterns, eating patterns? And pain assessment tools. A lot of pediatric pain assessment tools have been developed to assist children in relaying their level of pain. I know with our adult patients, typically we think about going in and, on a scale of 1 to 10, and they give you a number. Now, if we went into a 3-year-old's room and gave that same spiel on a scale of 1 to 10, we may get a response that says, they may tell us 100, 1,000,000, 50,000, because they have no idea what we're really asking them. This is the FACES scale. You may be familiar with this. Probably one of the most popular ones that we think about. Instead of asking a child to give us a number, like on that 0 to 10 or 1 to 10 scale, we can have them look at this series of faces, and we can give them an explanation. This is a child who has no hurt, who hurts a little bit, and on down the line. Point to the face that shows how much hurt you have. Now, you will see that there are numbers on there. But those numbers are really for the caregiver so that we can, in our documentation, indicate using the FACES scale, patient indicated pain at a 2, instead of having to draw that little face in your nursing notes. So again, that's probably one of the most popular ones, probably one that you'll see frequently being used at your clinical settings. There are other types. These are just some examples from your textbook as well. You can look at them in your textbook again in more detail as well. Again, kind of based on that same thing of that scale, but we could have them look along the scale as opposed to actually picking a number on that. This is something for an adolescent. Again, you can see giving them some words, and they can kind of go through and describe some of those words that may relate to their pain. A few things just with the treatment of pain in children, and these statements all do come from your textbook as well, but just to kind of quickly go through them. Children will benefit from a combination of non-pharmacologic and pharmacologic methods of pain management. Certainly when we've got a child in pain, the pharmacology is important. Looking at what medications may help ease this child's pain. But in combination with that, what are some other non-pharmacologic interventions that we could employ? With an infant, that might be swaddling them, holding them, rocking them, giving them a pacifier. With another child, it might be distraction techniques, maybe music, maybe guided imagery. And actually some of those things are listed in that second bullet point. The last bullet point, few analgesics are administered intramuscular, given IM to children. In regards to IM medications, you're probably going to get through this 5-week rotation without ever giving an IM injection. We really try to avoid those as much as possible in peds. Probably the most a child's going to get IM injections are with their immunizations, and with the rotations that you're doing at the clinical facilities, you really won't have an opportunity, my guess would be, to do any immunizations. IV, certainly if we have IV access, is going to be our choice. PCAs can be used in children. Just because it's a pediatric patient doesn't mean that they can't have a PCA. Would a 18-month-old have a PCA? Probably not. Could a 5-year-old have a PCA? Absolutely. This is just a discussion question that I put on here, just something to think about. What if a child is scheduled to have a bone marrow aspiration at 10, and to prepare for this you apply EMLA cream at 9 a.m. The surgeon who's going to do the aspiration arrives early. Well, first of all, we know that this probably is just a fantasy, because when would a surgeon probably or a physician ever arrive early for any type of procedure? But who knows what's going on in this scenario. They come in early. What would we ask the surgeon to wait for the hour, or explain to the child that the cream is not going to work? Well, I hope you all have immediately answered, we're going to be the patient advocate and ask that surgeon to wait for the hour. Because EMLA cream does take about an hour in order to be effective. Just a few things about EMLA cream. I know they talk about EMLA cream in those videos that you're going to watch during week 1 reflection. I believe they also refer to it in this chapter in your textbook as well. EMLA cream, the EMLA stands for Eutectic Mixture of Local Anesthetics. It's topical anesthetic that can be used prior to IM injections, as in this instance, prior to like a bone marrow aspiration. You can use it prior to an IV start. It comes in just almost like a little mini kind of toothpaste looking tube. You apply it to the site, cover it with the op-site dressing, let it stay on for about an hour. Take the dressing off, wipe off the cream, and then prep the site as appropriate for whatever procedure you're going to do. One thing to mention with EMLA cream, it does require a physician's order. You as the nurse cannot just decide you're going to use EMLA cream. Unless there's a standing order at your facility, or if you've gotten a specific written or verbal order from a physician. Another critical thinking activity, it says Robin's a 3-year-old admitted to your hospital unit for a severe burn on her hand. When she's seen in the emergency room, she was screaming with pain and got IV morphine. It's an hour later. Mom asks you if Robin can have some additional morphine. Mom says she's not having pain yet, but I want her to have something before the pain comes back. Is this mother's assessment of her child's pain apt to be accurate? Would this be the best intervention? Well, child safety, patient safety is always our top priority. Yes, we don't want her to have pain. We want to keep her pain managed. The issue here probably becomes, is it safe to give another dose of morphine an hour after you've just given a dose? We'd have to go back to look at our orders. Are our orders for every hour, or are they maybe every 2 to 3 hours, or maybe every 4 hours? If that's the case, we can certainly address mom's concern. We could maybe look at, is the morphine not managing her pain? Do we need to get some orders for additional medications? Do we need to increase her dose? But again, you always need to think about patient safety first. Just because, you agree with mom, yeah, I don't want her to get, that pain level very high again, but is it safe to give that IV morphine again at this time? Another question to think about, a 6-year-old girl scheduled for daily debridement of a pressure ulcer for a very painful procedure. She screams before the procedure begins. What type of pain management should be used? How should the child's anxiety be addressed? Obviously, we'd like to give her some pain medication and allow it time to work before we do that pressure ulcer. At 6 years of age, what might be some things we could use? Maybe some distraction techniques, maybe some guided imagery, maybe listening to some music, putting some headphones on, someone reading a story to her during the debridement. We probably would really have to work with this child, because if she's already had this procedure done and knows it's a lot of pain, it's going to take a lot of work to try to get that anxiety level down so she's not fearful of that. But again, using the pharmacologic and non-pharmacologic interventions is appropriate. Again, we've probably already touched on this a little bit with pain management, certainly dependent on the child's age, degree, and type of pain in terms of what interventions are going to be the most appropriate. And some of these things I've already mentioned, what could be some non-pharmacologic pain management techniques that as the nurse you could employ. Distraction, that works great with kids. Again, put in a video, get them blowing bubbles, the music therapy, certainly going back to massage, application of heat and cold, some tried and true techniques. The topical anesthetic cream or the EMLA cream, as we're getting into pharmacologic pain management, oral analgesia. The IM injections, again, not used very often. IV administration, definitely preferred over that IM injection.